All right, Dr. Rios, we are good to go.
Okay.
We have to mute.
I'm Dr. Elena Rios. I'd like to welcome everybody to the National Hispanic Medical Association COVID-19 virtual briefing series. This is session number 5. Happy New Year. We are starting our sessions up now that it is 2021. And today we are going to discuss the issue of building vaccine confidence. Next slide, please, Vincent. We have some housekeeping rules with our webinars. This webinar is 1 hour long, and we stay an extra 15 minutes for some discussions from the audience. We have presentations, 10, 12-minute presentations, 3 of them that will be followed by a Q&A discussion. We would like all the audience to join in with asking your questions by typing into the chat box at the bottom of the screen. Microphones, please mute all your microphones to allow more internet acceptance here. We also would like to let you know that we are recording this session. We are also on Facebook Live, and the recording will be available next week. We do a little bit of editing. Our website is www.nhmamd.org. I have a few slides just on some vaccine confidence background to get everybody thinking along the same lines. Go ahead, next slide. So COVID-19 data, January 26th, and this is taken from the New York Times COVID-19 dashboard. We are focusing on 2 areas of the country. Our 2 speakers tonight, we have 3 speakers, but 2 speakers will be from New York City and the Los Angeles metro area. So I thought I'd put up these slides. The latest cases, this is, so you can see compared to the United States, the cases in New York City and in Los Angeles County and metro area are much higher than the United States. Although you can see that we have a negative 8% of the cases coming down for New York and a negative 45% of cases coming down in Los Angeles. So a little bit of positive note there. Our daily deaths also in Los Angeles a lot higher than the United States or in New York, but still pretty high. We're not too concerned about the numbers. I just want to give you the trend. The average state vaccination rate right now is about 5.5% of the whole US population, and this is across the states and the territories. Since December when they were started, the 2 vaccines that we have now in the United States are from Pfizer and Moderna, and Pfizer also uses and has another company, I believe it's BioNTech. The Biden administration plan is to have a 50% increase. So with the new administration, they're planning and getting their experts together. They're planning together a lot of plans, but they are trying to move the needle upward. So again, a very positive trend. New York has a 19% population of Latinos. This is the New York State population. And there is about 24% of Latinos that are actually dying, the death rates, according to the Boston University and Atlantic dashboard. The California population is much greater in terms of Latino population, almost 40%. And they are 54% of the cases and 47% of the deaths. And I have to say that to Dr. Flores from New York, you need to do some advocacy in New York. They do not collect racial ethnic data for cases. Next, at least that's what I've found out. Next slide. So from the Kaiser Family Foundation, they just did a very well done study of looking at racial ethnic minorities and vaccine uptake. So I'm just going to go through a few of these slides really fast. First one says that 7 in 10 Hispanic adults that were surveyed say that they will get a COVID-19 vaccine. And I think that you can see that African American, Hispanic, and white definitely will get it, probably will get it. And then you see in the green, they won't get it or they don't think they will. So there's a much more positive acceptance rate of the vaccines right now. Go ahead. I think people are tired of staying indoors. That's what's going on. 1 in 4 Hispanic adults say they will get the vaccine as soon as possible. 4 in 10 want to wait and see. So we have a problem of hesitancy. And as you can see in the pie chart there, the dark blue is wait and see people. Next slide. Among Hispanics, larger shares of younger adults and essential workers express vaccine hesitancy. This is very important for us to start thinking about messages that will attract the younger adults, that will convince them, that will persuade them, and also for the essential workers who have to go out and be around more people. You know, it just makes sense that we should target our strategies to these two groups. Next slide. This slide says that nearly 7 in 10 older Hispanic adults are confident the development of a COVID-19 vaccine considers people like them. This is amazing considering historically very few minorities, very few Latinos, given all the barriers that we know we will discuss, get involved in research. And doctors in our communities that are so busy, you know, have very little time to explain to people that you should get involved in clinical trials or research. So this is another great positive note from this study. Next slide. Younger Hispanic adults are less trusting of political sources of information. But, you know, what's important here, I'm not going to, and I want to tell everybody, we're really not concerned about political or politics at this point. We're very interested in understanding how do we get to the Hispanic population that is the backbone of our communities and essential workers to think about getting vaccinated. But I will tell you from this slide, if you look at the very top trusted source of information is a personal doctor. And that's what NHMA wants to do is educate more doctors who take care of Hispanic patients and others about how to get them to get vaccinated. Next slide. So this is just a framework. The National Hispanic Medical Association is working with the White House COVID-19 Health Equity Task Force. We met with them just briefly during the transition and were asked to try to come up with champions and leaders in our different health professional organizations, Hispanic doctors, pharmacists, dentists, public health leaders that we have in our network to be able to help them understand, again, the strategies from the experience-based communications that work. So I think that we need to look at messages that are trusting, that have transparency because there has been a lot of discrimination in research. There's a big fear for deportation among our immigrants. And there's a feeling of disrespect at times from authority figures. There also needs to be a real focus on information and that we have information that includes health literacy, not only about healthcare and getting the vaccine, but in the public health infrastructure and how to deliver the message and who the messengers should be. We need physician training because we have so few Hispanic physicians. We know only 5% of the doctors in the country are Hispanic. We really do need to have more Latino health professionals work on patient communication and medical record reminders, of course, that the CDC has always told us is important for vaccinations of their patients, doctors' patients. But we also need to have education of the staff. And the staff spends a lot of time with patients in our community health centers and in our doctor's offices. And I mentioned the class standards only because for those of you that don't know it, the Office of Minority Health has put out a guideline for talking to minorities that is culturally and linguistically appropriate. And then we need social needs to be taken care of. There's a lot of websites or call lines to get appointments. There's apps. Every state and territory is a little different, and we need to help our community with online navigation, transportation, childcare, and other things. And then lastly, we really do need media campaigns, and NHMA has already partnered with the Ad Council with their campaign that's about to hit the airwaves. Dr. Fauci is a part of it, and several different organizations. But we also need to work with social media to get to the youth, newsletters, websites, etc. And just a plug for the NHMA portal, we have a portal called hispanichealth.info, and we have a hub of COVID-19 information that we will be expanding with support with some of our partners. And I don't want to mention our partners, I just want to mention CDC because our next speaker is from CDC. And we're very happy to announce that we will be working with CDC, I believe, starting in the next week or two on our campaigns and our hub. Next slide. So it gives me great pleasure to have our first speaker from CDC, Captain Janell Routh, who is going to be talking about the COVID-19 vaccine development and distribution. Dr. Routh, can you please take it away?
Dr. Rios, thank you very much, and really appreciate everybody having me here this evening to talk through vaccines and vaccine implementation. Next slide, please. So I'd like to start with a look at where we're currently at. As of January 25th, which was Monday, we've distributed over 40 million doses of vaccine, and 19 million people have received their first dose, with over 3 million having received their second. Rollout is occurring across all 50 states and US territories, and not surprising, there's been slightly more Pfizer administered than Moderna, since we know that the Pfizer vaccine was authorized a week earlier. All in all, I'm proud to be part of this effort that the jurisdictions have made to get vaccine out to those first groups suggested for vaccination. I think they've distributed more vaccine in 6 weeks than they typically do in 6 months, so this is a great achievement. Next slide. And so who is this vaccine being distributed to and administered to? I like to think about implementation as an early phase and a late phase process. So in the early phase, we've got a limited supply of vaccine, and we're carefully focusing on certain priority groups. In this case, at least over the past couple months, that's been healthcare providers and residents of long-term care facilities. And we've been distributing as well to the public health clinics to try to get some of those healthcare providers rapidly vaccinated. But later in the distribution, as our vaccine supply increases, we want to work to get vaccine distributed more broadly and through a wide variety of administration sites, which, through that wide variety, we really want to focus on both efficiency and ensuring equity. So that vaccine is distributed to those groups that may need special thought around access to vaccines. So for example, we're thinking through pharmacy distribution, mobile units, federally qualified health centers, and then also thinking about techniques like mass vaccination clinics or large outpatient clinics to really get that access expanded. Next slide. So as we look at this slide, I really want to remind us that the COVID-19 vaccination program is dynamic, and it requires ongoing assessment as vaccine supply and demand change, and also the epidemiology of the pandemic changes. Using these data, we can really inform the rollout of subsequent phases. ACIP, the Advisory Committee on Immunization Practices, and CDC have endorsed guiding principles for efficient distribution as well as jurisdictional flexibility for the COVID-19 vaccine program. So while this slide shows the different phases and their respective recommended populations, such as phase 1A, as I mentioned, with healthcare workers and long-term care facility residents, we've given jurisdictions, our state partners, the flexibility to really administer this guidance in the best way that they see fit for their populations. So we emphasize that within each jurisdiction, it's not necessarily important to finish one particular phase before moving on to the next. Again, as vaccine supply becomes more readily available, we really want to see that expansion happening as quickly as possible. Demand for vaccine and implementation challenges do vary from one state to the next. So when and how jurisdictions move through these different phases is unique. We definitely know that some jurisdictions are still focusing on phase 1 populations. Some have actually moved into that phase 1B, 1C population, which would encompass those essential workers and persons over 75. So again, it's jurisdiction dependent where we're seeing vaccine rollout happening right now. I'm hoping that over time, over the next few months, we're going to get to a place where we really do expand access to phase 2, which is essentially all persons aged 16 and up would be eligible for vaccination. Next slide, please. So essential workers are those whose the work that they do is essential to maintain critical infrastructure and to continue critical services and functions. Frontline essential workers are a subset of those essential workers who are likely at highest risk for exposure to the SARS-CoV-2 virus and subsequent infection and the development of COVID-19 disease. We know that these frontline essential workers often have the work that they do either on site, so in a congregate facility, or their work involves being in close proximity to other people. So within that 6 feet border that we say is appropriate social distancing. So we are really trying to focus and emphasize these frontline essential workers for prioritization around vaccination because of the work that they do. It's essential to our well-being and it's important to keep them safe. Again, I do want to point out when you look at the slide, we are giving jurisdictions the flexibility of who to prioritize in that essential worker population. So for example, Maine may prioritize essential workers a little bit differently than say California would. And though we give this list, we say it really is up to the state to decide how they want to prioritize. Next slide, please. So as most of you probably know, those 2 vaccines that have received emergency use authorizations, or EUA, after careful FDA review are the Pfizer-BioNTech vaccine, which is 2 doses given at least 21 days apart, and Moderna, which is another 2-dose vaccine given at least 28 days apart. I want to emphasize, and I'm going to continue to emphasize safety throughout this presentation because I think really understanding the safety profile of these vaccines is critical to our ability to promote confidence in the people who are receiving the vaccines. Both of these vaccines were tested in tens of thousands of adults from diverse backgrounds, including older adults and communities of color. Data from the clinical trials demonstrated that both vaccines had approximately 95% effectiveness in decreasing or in preventing COVID-19 disease. And I'll just say right now, one thing we don't know is how long that protection lasts. So CDC is currently developing and rolling out additional efficacy trials, effectiveness trials to be able to look at this very question. Next slide. So I wanted just to take a moment and talk about a little bit more granular detail of the pivotal trials that were shown to FDA in order to get those emergency use authorizations approved. Pfizer enrolled almost 45,000 people across 150 clinical sites in 39 states across the United States. The racial and ethnic distribution of participants was 13% Hispanic, 10% African American, 6% Asian, 1% Native American, and 45% of enrollees were between the ages of 56 and 85. Moderna enrolled 30,000 people across 89 clinical sites in 32 states, and had a racial and ethnic distribution that included 20% Hispanic, 10% African American, 4% Asian, and 3% other. 64% of their participants were aged 45 and older. So again, this is just some data to support the understanding that these clinical trials really were inclusive of both communities of color and older adults. Next slide. So both the Pfizer and Moderna vaccines were developed using mRNA technology, which is a new technology, although I will tell you that it has been around for a long time. It's just now been shifted to use for vaccine development. This technology teaches our cells essentially to make a harmless piece of what we call a spike protein, which is found on the surface of the SARS-CoV-2 virus. After that protein piece is made using that mRNA construct, the mRNA construct is broken down in our bodies. I know there's been a lot of concern from groups thinking that the molecule stays around in our cells, and there's even some thought, some concern that the mRNA molecule could actually get into the nucleus of the cell and interfere with our DNA or genetic material, but that's not true. The mRNA molecule is actually broken down quite quickly after that spike protein is made. And then, subsequently that spike protein is released, our immune system recognizes it as foreign, and that's how we develop antibodies that protect us from infection. Again, one myth that we'd like to overcome is that mRNA vaccines do not contain live virus, and so you cannot get COVID by getting vaccinated. Next slide, please. So, side effects after vaccination are a reality, and they are a reality of these two COVID vaccines that we have right now on the market. I think it is incredibly important that we do give everyone the facts so they know what to expect. And so we've tried to be very transparent in what people might expect after vaccination. And there may be people here that have some personal experience with this. Many people don't have any side effects from COVID-19 vaccines, but some people will. And it's usually pain or swelling at the injection site, fever, headache, or muscle aches. And these side effects are generally worse after the second dose. They typically don't last long, maybe 1 to 2 days. And it's really a sign that your immune system is reacting and you're building up resistance to SARS-CoV-2 because you've been vaccinated. So I try to spin it as a positive. The side effects are really your body telling you that it's responding to the vaccine. Again, I'll point out it's important to note that there were no safety concerns identified in the clinical trials, and at least 8 weeks of safety data were collected. It's unusual to have a side effect from a vaccination after 8 weeks of receiving that vaccine. And so I think that's why we had great confidence moving into the approval of both of these, that we were not seeing a safety signal. And as I'll mention in the next slides, we are continuing to track that safety signal, and I'll talk more about the mechanisms in just a minute. Next slide, please. So, we recognize that many folks do have concerns about the safety of these COVID-19 vaccines, but again, I want to reassure that they've been held to the same safety standards as all other vaccines.
I think that
I think she
Captain
got frozen.
Safety actually, oh, there we go.
There you go. Okay. Technology. Okay.
Gotta love it. So safety monitoring of these vaccines begins both before the authorization is approved, and it also continues afterwards. So before any vaccines receive authorization or approval, the Food and Drug Administration, the FDA, carefully reviews all safety data from those clinical trials. And then the Advisory Committee on Immunization Practices, or ACIP, as I mentioned, which is an independent body of experts, again, reviews all of that safety data before they recommend use. Both FDA and ACIP have qualified scientific and clinical experts with minimal conflicts of interest when they review the data. And then after vaccines are authorized and in use, we continue to monitor the safety of these vaccines closely. We have existing systems that can rapidly detect possible vaccine safety problems, and those systems are being scaled up for these COVID-19 vaccine rollout. So I wanted to speak particularly about two systems that we have in place. One is called VAERS, and this is a system that stands for the Vaccine Adverse Events Reporting System. It's been in existence for quite some time now, and it's the system by which we monitor all vaccine safety across the United States. So not just COVID, but other vaccines as well. This is a mechanism by which we collect reports from healthcare professionals, vaccine manufacturers, and the public. And it's a way we can rapidly look to see if there's a safety signal and then communicate that out to the public. The other really interesting system that was brought on board specifically for COVID-19 vaccine is called vSafe. And I'd like to talk a little bit more about that on the next slide. So vSafe is this really interesting active safety monitoring program for COVID-19 vaccines. And it's a smartphone-based program. It uses text messaging and web surveys to check in with vaccine recipients after vaccination. So the check-in period is set, I think it's daily for the first week, and then it spaces out a little bit. But this is a way that we can actually reach out to vaccine recipients and say, hey, how are you feeling today? If any health problems or other issues are reported, those go into a database and somebody makes a live active telephone call back to that vaccine recipient in order to follow up on those health concerns and see if it warrants a report. So in addition to VAERS, which is really, we sort of wait for the reports to come in, vSafe is a mechanism by which we're actually actively asking people what their adverse events are. Next slide, please. So, oh, and I should mention, when you do go to get your COVID-19 vaccine, you should be offered to be enrolled into vSafe. It's a voluntary system, but your provider should offer that to you. We've had over 2 million people across the United States accept that offer of vSafe. And so this is going to provide a really robust safety database for us to continue to look at these vaccines. So it's been really encouraging to see that support. So this is a really exciting and historic time. I think, you know, I do get choked up a little bit when I see people getting their vaccines, because I know all of the work at CDC that has been done behind the scenes to make that happen. But the pandemic continues and our work is definitely far from over. There are going to continue to be challenges. For example, the new variants that we're hearing about, and certainly vaccine hesitancy challenges that we're all speaking about this evening. But we are continuing to work together with our partners to find those needed solutions. And I think this is probably the most important part of my presentation. So I'm going to speak slowly and make sure everybody understands that vaccination represents just one tool in our toolbox. It's an important tool, but it's just one tool. Even after vaccination, we need to really promote and continue to encourage the message of the importance of masking, social distancing, and hand washing to really protect ourselves, our families, and our community. We know that community engagement is critical to vaccine implementation success. And I'm really looking forward to our discussion tonight. Encourage you all to have conversations with your community to combat hesitancy, be a role model for vaccination, and to share the resources and toolkits that we do have available at CDC. Next slide. So we have just a ton of communication resources right now up on the web, and I feel like more continue to get added daily. Right now, we're really focusing on a broad vaccinate with confidence message, but also really drilling in and developing specific toolkits for certain populations, essential workers, communities of color. And I think these toolkits will really have important information, all kinds of social messaging, posters, things like that to help you promote vaccine in your communities. So please go to cdc.gov and take a look at everything we have to offer here. Next slide. I think that's it for me. So I want to say thank you very much. It was really wonderful to speak with you and look forward to a lively discussion and Q&A at the end. Thanks.
Okay. Thank you,
Thank
Captain
you.
Ruth.
Okay.
Now we have Dr. Judy Flores, who comes to us from New York City. She is the past chairwoman of the NHMA Board of Directors and is very, very involved with the contact tracing and testing in New York City. Judy?
Okay, thank you so much. Thank you both for that introduction. And I will say, Captain, I'm part of Be Safe. So I get my call on my smartphone every week, and it's very reassuring. So I'm going to start with Próximo, the next slide, please. I'm going to start by sharing information on race and ethnicity, actually from New York City. We actually do keep race and ethnicity data in great detail. I will say perhaps it was not very accessible, but now it is quite out there and more to come. And one of the things I will tell you is one of my job basically now is to work in the New York City Test and Trace Corps. And we are the people that encourage and make available to many communities the ability to test often, test for free, and test without any fee, of course. We also make it available for them to participate in what we call contact tracing, which is when we make sure that we can follow up and help people in their isolation quarantine needs. So that is what I do now, and I work mostly with healthcare facilities, doing that with hospitals and home health aid agencies and the such, and independent practices. But I want to share the data from New York City. So we know that Hispanics and other communities of color have been overrepresented in the burden of COVID. So New York City cases, this is this month's data. If you look at Hispanic Latino data, we are way off the chart. I don't even have to read the number. This is just for this month. We've had over 4,000, nearly 5,000 cases of those people that wanted to be tested. Próximo. Next slide, please. Next slide, please. Yeah. So for hospitalizations, similar story. Again, this is for this month in New York City, and we do divide it up by race and ethnicity, and I'll go into that a little bit later on the third slide. Next slide. So fatalities, we've been really hit hard. Communities of color, the Black, African American, Hispanic, Latino, we've been hit very, very hard in the country and particularly in New York City. So we share the burden, unfortunately, and we have to look forward to being treated in an equitable fashion so that we can share in the treatment and the prevention. I will say something about this. I saw a question already on the chat about how do we divide up the Hispanic community and the Latinos in New York. I will tell you, and I cannot share the data because it's not published yet, but when we do contact tracing and when we do look at communities who participate, who don't participate, we break it down to not only the particular group of Hispanics, but where they live. So we know that the largest population in New York is Dominican, is from DR. The second largest population that is willing to give us race and ethnic information are Puerto Ricans, and the third one is Mexican. We also go down, we really do, and you will see this data probably published in the next few months, is how we approach these communities. We have a very different approach for each one of these communities. We go into their community, we talk to their community leaders, be they Hispanic, be they Russian, be they Caribbean, be they African American. We try to get our stakeholders in that community to help us with our work. So we do a lot of equity work, and we do a lot of very specific targeted work with our populations in New York. I will say that I'm very proud of that because we spent a lot of time on that. Next, please. So multiple layers of improved success. I think we're constantly thinking of, when we think of the work that we do in terms of prevention, in terms of stemming the tide of the pandemic, we look at the personal responsibility and the shared responsibilities. So we know that we have to hold on to the core four. We have to make sure we physically distance, we wear masks, we continue to wash our hands, and we try to stay out of crowded places, particularly indoors. But there is a shared responsibility, and that shared responsibility has to be quite equitable. It has to be for everyone. It has to be regardless of your politics, your economic situation, your station, your immigration situation, because I don't think COVID understands who is who. So we can get sick from everyone. And the best way to make sure that we are protected is to protect our neighbors and our community. So in our shared responsibility, that's where quarantine and isolation comes into play. And I'll talk a little bit more about that. Next, please. So I already described what goes on in New York City. By the way, this goes on in multiple cities. This is just one example. Many, many cities have very successful test, trace, and take care programs. I was reading about one in Arizona recently, and I've read a lot about and shared information with people from California and other states. But I'm going to give you the message from New York City today. So our New York City Test and Trace Corps is a combination of work that's done with the New York City Department of Health in association with the largest municipal hospital system in the country, which is New York City Health and Hospitals. We combine forces. I am, let's say I'm a New York City Health and Hospitals person. I also have a volunteer position with the New York City Department of Health. We have to work together. We pull together our resources to be able to combat this pandemic. So we obviously have three parts to our, at this point, we have three parts to our work. That's to make sure that we have testing available, that we're able to trace, which is identify cases and contacts and recommend isolation and quarantine, and take care. You can't recommend things to people that aren't able to do things. You can't tell someone to isolate when they have to take care of their children and their families, when they have to get food on the table and they can't miss their work. So we have developed a good take care program where we can actually provide hotels, we provide medical care, and we provide support for food for patients that have to isolate and cannot isolate at home. Next, please. So who should get tested? We have a vaccine, and even though we have a vaccine, people have to continue to be tested for many reasons. In New York, we basically encourage everyone to test as often as they want. We do not encourage people to test if they've just had an infection. We usually wait about 90 days or 3 months to be tested again, because you'll get a lot of false positives because of the dead mRNA virus that will be detected. We also are very, as I said, we spend a lot of time in New York City looking at equity. And I was pleased to hear today that the administration is also spending a lot of time looking at equity in distribution. We don't have any problems with immigration status. We do not ask. We also do not ask about money. And we do repeat diagnostic testing on people when they exhibit any signs, are concerned by a possible exposure, which occurs quite often, or work in a residential congregate setting. If you're working in a nursing home or a shelter, or if you're an independent person working and taking care of someone, private pay, which a lot of our community does, it is important for you to be protected, to use your PPE, and to be tested. And of course, with travel. Next, please. So what is contact tracing? The goal of contact tracing is to slow the spread of COVID. Of course, we want to carry out contact tracing at a rapid pace. And we actually do contact tracing very, very quickly. If we get results from the state lab, we have teams of people that can address these families, that can address our community and get people into a monitoring system or isolated or quarantined. Hopefully we made an impact at a time when the world is depending on public health. Next, please. So these are just terms. I'm sure most people know these terms, but there's always some confusion between quarantine and isolation. So isolation really separates sick people with contagious disease from others. Quarantine separates and restricts the movement of people who have been exposed to a contagious disease. That's a very big difference. If I'm in quarantine and I'm a contact of someone and I am an essential worker and my hospital needs me, I can go to work as long as I come back and observe my quarantine for the time. Now it's actually 10 days. It's also important to know things about who is a case and what is a contact, just to go over terms. A case is someone who has tested positive for COVID-19. A contact or close contact is a household member, an intimate partner, or someone who's providing care in a household. We have significant number of our population of Hispanics, and particularly in New York City, who work private care or work for agencies and are providing care in the home. We saw in New York in the first surge a significant number of cases and fatalities among these workers. And many of them who are, and I'll talk a little bit more about that later. And also anyone who spends more than 15 minutes, that's cumulative within 24 hours with a case, regardless of whether they were wearing a face mask. We all know how people wear face masks. Unless you're in a hospital and it's regulated, sometimes the mask doesn't stay over the nose and the mouth. So we often ask a lot of questions and try to support people and make sure that they have not had a close contact. Next slide, please. So what do contact tracers do? These are different categories that we have in New York, and I know we have them across the country, but basically it's very important to understand that a lot of their work is to engage the community, to outreach, to talk to people, to talk to them in their own language. We have outreach contact tracers that are from every ethnic group speak. I think at this point we have something like 10 different languages that they can speak. We also have a language line that we use, but we like to use the culturally appropriate approach. So there's a lot of engagements in order to inform people as to get information on what their symptoms are, get medical help, get them into isolation or quarantine, get them some help to do that. And sometimes we actually have to make sure that we get that service in the home. And many of these community engagement specialists work with resource navigators, and you see that there, to make sure that food and medical needs are addressed in their community. The monitoring aspect is when we call them up and see how they're doing and see if they've been able to maintain and encourage them to maintain their quarantine and their isolation. Next, please. So the work of the contact tracer is similar to the work of what we're trying to do with vaccine engagement, is trust. The personal questions are a challenge. And this is one of our contact tracers who's now a trainer. She volunteered to have her picture used tonight. She gave me a lot of examples of what many of the barriers they have when they are doing contact tracing. They have a lot of questions about access and resources. There's major concern about loss of employment. If you're supporting a large family or an extended family, you have to be able to bring home some money to be able to support that family. So there's a big concern about loss of employment. There's a discomfort in communities with sharing contact information. The biggest challenges she faces is convincing Latino residents to self-isolate at home. It is very difficult, especially with large families. So social distancing is often a privilege and not a right in many of the communities we serve. Next, please. So the information, just to make sure everybody understands, information that we gather in order to support people, in order to give services and bring services to families is always protected. None of this information is shared. It's really minimally used, and it is used as identifiers so that we can get back to the family and get them resources. And we never ask questions about status. Next slide. So this is an interesting look. I and others have been looking at barriers that impact COVID-19 prevention and vaccination among Latinos. They are very, very similar. We have a general, even though it is getting better, generally we have a lack of knowledge. That means the disease course, the symptomatology, what is isolation, what is quarantine. People are not familiar with what what is involved in developing a vaccine or what is involved in testing a vaccine. They also have lack of access to testing, which is still a key component of what we're doing to prevent the growth of this vaccine, the spread of this pandemic. The lack of health insurance is a big issue. It's still an issue. In New York, it's somewhat less because we do have, at least in New York City, we have access for those that are uninsured. I will say in other states, that's not the case. And it came up in one of the surveys that I was doing on contact tracing in other states, that their lack of insurance and medical home was a significant factor. If you're telling people to go get a vaccine, typically they want to go to their trusted medical provider. They don't have a trusted medical provider, it limits their access. And again, we talked about the lack of resources for isolation, making sure that things are in culturally concordant services in their own language and by their community members. There's also a fear and anxiety about isolation and stigma. People don't want to share the fact that they are COVID positive, and the lack of social support and loneliness due to isolation. We are very social and we do not like to be isolated from our family. And I think that that's one of the big things to push for vaccination, is that the fact that we get vaccinated completely will allow us once more to be with our family members. Next, please. So interventions proven effective in contact tracing are very similar to the interventions that we use now to engage around vaccine. We engage in a manner that preserves confidentiality. We're usually bilingual and bicultural in our approach, and community and concordant with the communities we serve. We already talked about the support that we have to give for health-related decisions. And we have to act as a credible resource. We have to be informed as the physician leaders in our community. We have to be up to date because people are getting a lot of misinformation from all sorts of sources. And if we are going to be a credible source of information, we have to be updated. Getting back to work and protecting our close family are motivators for vaccine, and they're also a motivator for people to pursue contact tracing. One of the things that we think may happen in the future is that through contact tracing, we may be able to engage people in vaccination, because in many cases, we will be able to get the contact tracing, the contacts of the cases earlier and encourage them to vaccinate. The other thing that is a big issue and a very positive thing is that we at this point are able to treat some people for COVID, which is something we couldn't do months ago. We do have monoclonal antibodies, and they are going to be much more available. So in order to get them to the people that need them early enough, contact tracing is going to be very important. Next, please. So we talked a little bit about extremely vulnerable populations. And one of them I always highlight are home care workers. As you can see the numbers here, the deaths were significant. They were significant throughout the country, and particularly we saw them in New York. Next, please. I also wanted to talk about resources. This is just a picture of the kinds of resources that we use for people when we're involving them in prevention and treatment around COVID. And as you see, our forms are in Spanish, in very low literacy, so that we can get things out to the community. Next, please. So healthcare providers play a critical role. And this is really my last slide, and it really is a summary of what I was saying before. We need to encourage patients to get tested and isolate when they receive their results. This is very important. This is the only way we're going to stem the tide, because people will continue to be infected, even among healthcare providers. I don't see the engagement level yet to the point that we can say we are out of the woods with that population. We need to educate our patients on what to expect if they are test positive, become informed about the availability of resources in our communities. We have to be the go-to person to get them those resources in many cases, at least direct them appropriately. We have to become a reliable resource and advocate in advocacy and equity in prevention treatment, and vaccination. And I did mention a little bit about the work of using monoclonal antibodies as treatment. So let them know, please let them know when you're vaccinated. Be honest. If you are asking your patients and the populations you serve to be vaccinated, consider letting them know that you've been vaccinated and what your situation is. That is very, very positive and very engaging. Next slide, please. So thank you so much.
Thank you, Judy.
Okay.
We'll ask some questions afterwards. So it gives me great pleasure now to introduce from Los Angeles, the one and only Dr. Ilan Shapiro, who's done a lot of media now on Univision and Telemundo there in Los Angeles. And I have to give him a big plug for being the NHMA Southern California chapter co-leader. Ilan, take it away. Thank you.
Thank you so much, Elena. And because we have already 10 minutes for this part, Vincent, if you can actually take away the chat, there will be the slides, and just have the camera, that will be awesome. Well, in the meantime, one of the things that I actually wanted to convey with all of you is that right now we are in a problem with communication, and that's actually the hardest thing. And the thing that I want to convey to all of you and this open table is that we have been trying to convey a message. And right now, the initial part, and I have seen the questions that they are actually sending to us, most of the efforts at the beginning is just translating what we have with other vaccines and translating it from English to Spanish. Is that efficient? Probably for the first 3 seconds, and probably for 10% of the population. But if you go again and you think about not just translating, but making it culturally and efficient, and not only that, because we know now with the accent that we have here, with the 3 or 4 speakers that we have around us, that all of us already have different factors. We're Mexican Americans, we're just Americans, we are from Puerto Rico, we're from Cuba, we're from a lot of places right now, and all of us have different ways to express our feelings with vaccines. My dearest and most deepest concern that I have right now is that we'll have millions of vaccines ready in the following next weeks. I do believe so. They are ramping up. There's money coming. You know, you can see what's happening in the Dodger Stadium. They open a huge center. Same thing as the Disneyland parking lot. It's huge, and a lot of efforts that I'm seeing here locally, they are going every in a lot of places. And the problem that we're having right now is that we will have, we were solving the problem of demand. We will have the vaccine. But if you ask my questions, the patients that I have here in East LA, the families, and you ask them, the ones in Boyle Heights or in Orange County, they will tell you that they will wait. They will wait. They are not ready. And that's a problem, because we will have the thing that we know that it's going to be helping. We already heard, these amazing experts showcasing the data that our community has been the deepest, severely damaged. It seems that this virus actually, looks for Hispanos in order to kill them or punish them. In reality, sadly, it's not the case. It's decades of a lot of the social determinants of health on our communities. And as part of that, there's a lot of issues with food scarcity, problems with a lot of the things that we have with education, a lot of problems with healthcare delivery. And right now, this is just showing how decades of problems, the same thing with the African-American community. It's just showcasing how, a community, when you stress it and they don't have enough resources to actually bounce back, they will suffer more and will die more. Then this is actually a wake-up call. Then part of the solution that we want, and part of the economy that depends on a lot of, we're still a huge percent of the economy. And we are a huge percent of what actually going to be the reactivation of the economy, because we are there doing a lot of services in the front lines. Then unless we actually get the shields and the protection, it's not going to work. And what I'm actually proposing is we need to start vaccinating our community with a dose of, against fear, with a dose of truth. And I'm not going to get tired of saying that phrase. at this moment, we need to make sure that we are conveying the message. We have learned a lot from a lot of other groups in healthcare, and we know that we're competing against WhatsApp messages, we're competing against Facebook messages, Twitter, and Instagram. And that's kind of the way that everything is finding. Why? Because our community, is not that they don't want to get vaccinated. They love vaccine. In Mexico, and understand that vaccine saves lives. And people actually will get like the polio drops like billions of times just to get them because they feel more protected. And we know that, and we have it inside of us. The problem is, how are we going to win against all this crowded information that is around us? And right now, the objective of the efforts that we have with the Ad Council, with actually directly talking with the pharma, talking with the CDC, and everybody else that is involved, is to make sure that we're creating messages that are tailored to us. That's the most important thing. And by us, it means that, whoever is in New York, it will be, with Dr. Flores, will be way different from the people that I'm seeing here in East LA.
I think though, I do want to tell you, we're not that different, because our Mexican population here comes from Puebla, and we've been working in other places, and we've been working here. They have about a 15-year history here as being predominant. And they, and I agree with you, we have to look at different pockets of population. We might not be that different. I think the one thing that I see across the board is that people trust their community leaders, people that look like them, people that talk like them. If you talk to your patients and they see that you get the shot and they trust you, that's going to be much more powerful, especially than government or pharma. Those are things that aren't really trusted much. Fauci, yes, people trust Fauci. So far, they seem to trust Fauci, but they'll trust you, and they may trust me much more if they look like me and they see what I do. So I think that that's the power that we have. I actually agree with you wholeheartedly that we need to get out there and get the message, but we need to put the message out there. And people that, in other communities, I work a lot with African-American communities. That's the one thing about New York, there's a lot of diversity here. They really have a historical burden to be addressed. So I'm very happy.
I completely agree with you, Dr. Flores. And the objective of this is to make sure that I was actually addressing one of the questions that they had from on the chat box below. So, make sure to have that. Then what?
Ilan, do you want to wrap up or so I can?
I will gladly start doing that part. It's extremely important that a couple of things that our community actually wants to actually be heard. Our community wants actually to be part of the conversation, but they are actually, I was part of the Univision phone call national booth here. And the questions when we were talking about COVID-19, when they were calling us, they were calling about food, they were calling about rent and healthcare. And yes, there's a pandemic, but that's three things were the things that we need to solve right now in order to actually preach the message. Then if we want to talk about vaccines, we need to make sure that we're talking and resonating that this is actually the pathway to make sure that the problems that you have had in your family, the rent part, the problems that you have had with education, everything that we have here and you have been suffering for 12 months and probably you have lost a lot of family members or you actually are suffering right now and you have chronic, COVID long haulers thing. Probably yes. Then unless we are breaching the real problems that we're having in the community and using the vaccine as a tool to get to actually the saving our community, we are not going to be, on that part. I'm going to leave my information on the chat box. Dr. Rios, thank you so much. Dr. Flores and Dr. Routh, I need to run right now to another conversation. Thank you so much for the information. I'm always here to interact. I actually took the liberty to answer some questions on the chat box, and for sure, we're in this together, and we need to start doing the conversation today in order to have the vaccine and the messaging ready for in 1 month. Then,
Ilan, just before you leave, I want to thank you very much. I know you have to. I didn't know you had to leave, but okay, I understand. We are very interested in finding more champions like yourself in Los Angeles interested in becoming influencers and spokespersons, and please help us find them. We are starting a very big project in with Los Angeles and New York City, especially for CDC. And we also have another project that we are discussing with the Rockefeller Foundation that's going to take a look at certain other areas, Newark, New Jersey, Chicago, Oakland, California. They're specific. But what we need are the influencers that are out there, especially those who you already know, Ilan, because you've been in Florida, you've been in Chicago, and you've been in Los Angeles. And I know you very, very well connected to the consulates of Mexico, the Ventanillas de Salud, which is another very, very important public health infrastructure we have. So thank you very much. And
Thank you so much.
We have questions that I do want to ask. I want to ask a few of the questions because even though Ilan answered some of them, we are on Facebook Live, and for those on Facebook Live, they don't have access to our Zoom chat. So let me ask Captain Routh from the CDC and maybe some of the scientific knowledge. One of the first questions that came up was if you already had the disease, COVID-19, do you recommend getting vaccinated?
We absolutely do.
Absolutely.
So, yes.
Okay. And, no, go ahead.
Yes, I could just say, you know, we don't know how long that immune protection is once you've had COVID. Does it last 6 months? Does it last a year? Does it last forever? You know, that's a question that we're still answering. And so we absolutely recommend, even if you've had COVID, please continue to
get vaccinated.
Vaccination.
Definitely. Okay.
Another question for Captain Routh. Again, you showed a slide of the essential workers, and someone asked, are CNAs on that list?
Yes, so certified nurse assistants would be considered healthcare workers and recommended to get their vaccine right now.
Okay, let me go to Judy because you talked about the importance of looking at different groups of Hispanics and how important it is to work with community leaders.
Yes.
So what are you doing, and maybe you can just in a couple of sentences, to bring in the different diversity among the Hispanics in planning your activities?
Yes, what we do is we work with community organizations. For example, last week I worked with a church group that invited me, but their main speaker was someone from the Caribbean community. It was a church group. That was part of last week. The other part of the week I worked with a Mexican American group that is also a CBO. So we work with community organizations. We've had some challenges with some communities that don't want to be tested, that don't want to isolate because of other reasons. And we always look to their community leaders, and we also, of the 2,500 contact tracers, they are of every diversity and every community and every race and ethnicity. So we make sure, and we do keep, as I say, we meet every week to look at our racial and ethnic and equity standards. So we are very tuned to that.
Okay, Captain Routh, another question that just came in, and please, if anyone has questions, please put them in the chat box or the question and answer. If you take your second dose, both the Pfizer and the Moderna vaccines right now require 2 doses about a month apart. If you take the second dose earlier than a month, is that okay? Is there an issue?
So we do have a 4-day window period, 4-day grace period on either side of that 21 or 28-day window. And so, for example, if say for Pfizer, if you got it on day 17 instead of 21, that would be just fine. So there's that 4-day grace period. We've also had some feedback about the fact that it can be very difficult in some situations to follow up with that second dose at day 21 or day 28. That is our goal. So I do want to emphasize here that we recommend that window period in order to get the second dose of the vaccine. But if you can't, the guidance now says it's acceptable to get that second dose up to 6 weeks or 42 days after the first. So there's been some relaxation there because of difficult circumstances for many vaccine recipients.
That's good to know. Judy, on one of your slides, you mentioned the importance of fear and stigma and anxiety. So how do you deal with that? Just in some very brief communications.
Brief communications is, remember, we do a lot of our communications on the phone. So on the phone, the first thing is when you introduce yourself stating to someone that this is confidential information. We are here to provide a service. We are here to keep you well and keep your family safe. That's right away. If you do it in the person's language, it's much more effective. So always reassuring people that whatever they share with us is not going to be shared. And also that whatever they share with us does not impact. We never ask about their immigration status, and it doesn't impact any, of the regulations related to them being able to obtain citizenship in the future or obtain any kind of social service. So right off the bat, we open up with that discussion to gain trust. As I said, the big thing is to get trust and assure confidentiality.
Captain Routh, to go along with the fear among Hispanics, especially those who are undocumented or have family members that are undocumented, does I'll give just one example, the program that you mentioned for people to be aware of their symptoms and to report it to the CDC, do you require identification in terms of citizenship?
Not at all. So citizenship and residency should not be a factor in receiving a COVID vaccine. And that VSafe program, it does require a cell phone, but we do not require any proof of citizenship in order to enroll.
And one other question about vaccines, what's the cost?
There is no cost. It is free.
If you get it at a pharmacy, or if you get it at a school, you get it at a clinic.
That is correct.
Cost.
The federal government has purchased all vaccines for the general population. Yeah.
Very good. Judy, somebody mentioned on the chat that they heard that IDs were being required in New York State. Now, I had to use an ID just to show age.
No,
but I mean,
what is required, IDs are, some form of ID is required because it is a healthcare visit. They certainly don't require anything that relates to your citizenship or your status, but it could be a driver's license, it could be a library card, it could be a healthcare, some kind of health card. You have to know who you're giving an immunization to. So some form of ID is always required whenever you do a medical visit, but it has nothing to do with your status or your economic status or immigration status. But it makes sense. You can't give someone a vaccine. You don't know how old they are. You don't know a lot of information. Other pieces of information that they may ask are, they'll ask you your age. They'll ask you if you've been sick recently, if you've ever had COVID, if you have a travel history, if you have allergies. So those are basic questions. There isn't, and I'm sure the captain can go over this, but there has to be some kind of verification as to who you are when you're giving someone a vaccine.
So there's another question, I'll just answer it briefly, and Captain, please help me here. We said the cost is free for the vaccine, but again, someone mentioned they've heard of administrative fees, and I believe that refers to all the equipment that's needed to give a vaccine, the syringes, the alcohol swabs, the
staff.
and all of and the staff, the personnel. Yes, of course, there are costs to the provider providing the vaccines. Do you know of any reimbursement and perhaps through, the Centers for Medicare and Medicaid Services, reimbursed clinics, reimbursed doctors, reimbursed hospitals for care? Are they reimbursing the pharmacies or the grocery stores that are providing the staff now?
Right. So an administration fee can be charged against insurance, and if the person does not have insurance, the CARES Act through HRSA can provide some compensation to that provider. But all providers sign a provider agreement, and in that provider agreement, it says that they cannot refuse vaccine because of administration costs.
Exactly.
Okay, very good. I think there was a few questions that Dr. Shapiro actually answered. One of them was, do we have resources in Spanish? And I know Captain Routh, you mentioned about could you give us the CDC's website? And if you
Just
can
put it in the chat.
Can
We
you
can put
type
in
it
the
into
chat.
the chat?
Put in the chat, yeah.
And can you give it to us verbally for those who are on Facebook Live? So someone is on our call who's from Juarez, Mexico, right across the US-Mexico border, and would like to have more resources in Spanish. And I'll have to say that I did put in our hispanichealth.info portal, and we are developing more information in Spanish. And anybody on the call who would like to help us with developing materials, we'd be happy to have you help us. Captain,
Yeah, materials are hard to find.
Well, we're going to develop them. Captain, do
Yes.
you want to say your website?
Yes, so let me just say, and I will put it in the chat, it's easy to remember, www.cdc.gov, G-O-V as in Victor. And on that website, you will find information in Spanish. So we are trying very hard to keep up with the materials we're developing to have a companion Spanish translation. Right now, we've got VSafe posters and fact sheets in Spanish. We've got a pre-vaccination patient checklist in Spanish, plain language facts about COVID and COVID vaccines in Spanish. So, and actually many of our CDC web pages can actually be translated to other languages by just clicking the language button directly under the web page title.
Yeah.
So please visit, I'll put it in the chat as well. And there are many materials there that you can share with your patients and colleagues.
Okay, so let me get back to Vincent for a second. Vincent, we have a very brief survey. People are still on our webinar. Can you put that on there? Okay, so I'd like everybody on the call who's with us who can type in an answer to this. What is a keyword or a phrase that you use to persuade your patients to encourage them to get the COVID-19 vaccine? We have a couple of minutes left. If you type them into the chat box, we will be able to record them and use them for our development of more tools for all of you. Okay, and I'm not going to read them. Just go ahead and type them in. I have a question for you, Captain Routh. The CDC rollout, you know, I know, and I don't want to put you on any kind of a timeline. We don't want to know timelines. We just want to know the trend. How do you see the distribution to our Hispanic communities? You know, we're everywhere, but there are the farm workers, for example, have been in the news getting vaccinated. I think that's wonderful. What other areas of the country are you focused on, or you know, in terms of increasing are you following the data, for example, and going where the surges are, or how are you planning distributions to our communities?
Right, Dr. Rios, so I think it's really twofold, right? One, we want efficient distribution of vaccine, but we also want equitable distribution of vaccine. Yes. And so we are looking at our data and trying to determine the best places to target vaccine for some of our underserved communities. I think one aspect that we're really trying to do is think creatively about how to get vaccine out to those communities. So for example, you mentioned farm workers, rural communities, communities in inner cities. How best do we successfully get vaccine into those communities? So thinking about partnerships, I think that really is something that we've been working hard on, partnerships across the US government, but also private, public-private partnerships. So partnerships with retail pharmacies, partnerships with federally qualified health centers. These are just two of the programs that are going to be rolling out very soon in order, again, to get vaccine where it needs to be.
Yeah, and I want to thank you for even considering the idea of getting mobile clinics into rural areas and into the neighborhoods. So many of the people that are isolated are older or elderly and just, you know, can't get up and walk to the neighborhood pharmacy.
Well, so, does that speak to, I want to ask a question, and I know that once we have the availability with the more portable vaccine, we can go into homes. So that's a big issue for us, is getting the vaccine delivered to people that are homebound. They certainly fit the category. Most of them are in some kind of home care, or they cannot make it out. So I'm hoping that we have that soon, that availability to bring it to a more central place and possibly to a home.
Dr. Flores, we're actually working on that right now.
I know, I heard a little bit about it. So I'm delighted. I am delighted. And the other thing is that we do have essential workers, and we do have communities of people that perhaps work in an unofficial capacity and do home care and are very exposed, and looking at how they are going to be engaged and how they will be included.
Right.
So I know we're at the time we're going to have to end right now in a minute or so, and I want to thank everybody for their ideas. We will put them together. We have another. This is our contact information for NHMA. Our website again is www.nhmamd.org. I want to give a plug to our conference. It's going to be virtual, and if you go to our website, you can register for the conference starting March 17th through the 20th. We'll have a lot more information on COVID-19 materials and resources. We'll have an exhibit hall that people can download information, and we will have our CDC project up and running. We also have Twitter, Facebook, Instagram, etc. Next slide. And I believe we have the last slide. It talks about the importance of this briefing series. It is a monthly series. It's the last Wednesday of each month, all this year, except for March because of our conference, and December because it'll be the holidays, the Christmas holidays. We are very interested in finding more ideas on topics, and we will be talking about the distribution and how to get an appointment and more specifics so that people can share that with your families and patients. And again, we're looking for anyone who is interested in helping us with developing the Spanish materials and helping to share information. And I know there was someone mentioned about community-based organizations. I just want to give a plug. NHMA, although we are a medical association, we are very much interested in partnering with community-based organizations that are in our 17 markets around the country. And if you go to our website, and I can send it to people that are here, we actually have 17 chapters from California to New York, and in between, Chicago, Texas, the Gulf Coast, Miami, even Atlanta. And we are very interested in connecting to the community-based organizations through our chapter leaders like Dr. Flores and Dr. Shapiro today. So I want to thank you, Captain Routh, from the CDC for being with us today. And,
thank you. It's a pleasure. It's a pleasure being with you.
And I want to thank Dr. Flores from New York City, testing and tracing, and Dr. Shapiro from the AltaMed Health Services, very large FQHC in Los Angeles. I have to say my mother worked there before she retired. Oh, cool. And also to Vincent and all of our staff for pulling this together. And we're also looking for speakers. Captain, we'd be happy to have more speakers from CDC.
I'll keep that in mind and put out the word.
Okay. So thank you. Thank you
all
very much.
Good evening, everybody. Good evening.
Bye, everyone. Thank you.
Okay.
Buenas noches. Buenas noches.